I'm super excited that you invited Dr. McGrath to the podcast. I really don't know a lot about OCD, and especially not with how it intersects with substance use. So I'm super excited to get to have this conversation today, just honestly for myself.
I think it'll be a good conversation. I don't think it's anything that we usually talk about. So as we like to try to do on this podcast, let's talk about things that aren't always out there and see where it goes. So I'm excited to have him. Welcome to Connections, the podcast from addiction professionals of North Carolina, where we explore addiction through the lens of policy and practice.
We're your hosts, Sara Howe and Morgan Coiner, and we're here to help you see how it all connects.
Today, we are excited to come to you live from APNC's Spring Conference in Lake Junaluska, North Carolina. We are here in Western North Carolina, back after Hurricane Helene. We are so glad to be here. There is a lot of recovery happening here. There is a lot of spring growth. We're excited to see it, and we're just happy to be back here in the mountains. So today, we are thrilled to bring Dr. Patrick McGrath. He is the Chief Clinical Officer of NOCD.com and the host of his own podcast in his own right, Getting to Know OCD. Welcome to the podcast.
Thank you. Good to be here. How are you all?
I got that podcast title right. Getting to Know OCD.
Get to know OCD.
Get to know. I was so close. Get to know OCD.
Well, you said NOCD, right? So that's good. Because sometimes people say NOCD or no OCD, but it's NOCD.
I've seen the commercials.
Yeah.
I'm up to speed on
our Howie Mandel commercials.
Your Howie Mandel commercials. But we're super excited to have you. I've listened to your podcast. I have seen the commercials, have intersected with individuals that have OCD in the past, and we haven't talked about this intersection with substance use.
Yeah, unfortunately, it happens on both sides, the mental health side and the substance abuse side, still kind of siloed. And I've been doing a lot of work to try to break those silos as much as possible.
That was one of the reasons I wanted to bring you in. In your experience and your background, you have worked in a residential center that actually coupled OCD treatment and SUD treatment side by side.
Yes.
And I don't mean they intersected per se, but there are individuals with substance use disorders, individuals with OCD that were alongside each other in a residential setting.
Yep.
So what made that work? What made you think those two could be side by side?
Well, the first inspiration was the fact that we know that people with anxiety disorders, if we go even broader than OCD, but OCD too, they use substances as a way to try to manage their feelings. Mm-hmm. And so when people were going to, say, residential treatment for OCD, they were told they had to be 90 days sober before going.
Oh, my.
Well, that's removing your safety behavior
really
for 3 months and asking you not to use that and having to deal with then all the OCD things, all the compulsions without your safety behavior, and then we'll treat you. I just thought that was ridiculously stupid. And I still think it's ridiculously stupid. So I was like, why can't we help? And then I met someone, Margaret Sisson. Margaret has been a big inspiration in my life. Her son, Riley, died of an overdose. Riley was in graduate school to become a therapist. Riley had OCD, and Riley learned early on, and I'm not giving anything away. She was just on my Get to Know OCD podcast, actually. So yeah, so you can see it all there. I'm not breaking any codes here, but Riley learned early on that if he drank, it could calm his brain down for a little while.
Sure.
And so there's this sadly unspoken thing out there, which is people with mental health conditions use substances as a way to manage their mental health. And on the flip side, people with substance use issues have mental health concerns that nobody talks about. When I was it's the Foglia Family Foundation Residential Treatment Center up in Chicago. When I was there, I remember meeting with someone one day who said he was on his 27th detox. Mm-hmm. And I said, well, that's a lot. Can I do a little interview with you? And sure. And so I went through my anxiety disorder interview, and he afterwards said, "You're the first person who's ever asked me about anxiety."
Oh, wow.
And I thought, I was shocked.
Why? Yeah.
Right.
Why hasn't anyone ever asked
I would
this?
miss that. Yeah.
And there's this unfortunate notion in a lot of mental health side of things where, those people with substance abuse, they have it and then they learn how to treat it and then they treat themselves. So we just let them do that. So we're going to talk about the mental health side. I could have gotten a PhD in clinical psychology without taking a substance abuse course.
That's so concerning. Yeah.
I know.
Yeah.
So
don't love that.
I audited a substance abuse course in another department because I felt that was horrible, how could I be a doctor and not know about substance use?
Yeah. I think that what you said is really interesting because, you started talking, you're like, oh, they're having to stop their safety behavior.
Right.
And even hearing you describe substance use that way actually feels very rare, even inside of this field, to say, oh, there's more than one issue going on.
Right.
And one of them is a behavior that is being used to cope with the other. Yes. Right? Like that, why, I'm like, that sounds, I don't feel like I hear that perspective a lot.
Right.
Right? Like,
it's a eye-opening perspective as we think about it. That is right. I mean, that is for them, that is keeping them safe in their mind.
Right.
And I think it's important for us to pause because OCD, this is my own opinion, but I feel like OCD in the public and in the media has been morphed into a funny joke, love Jack Nicholson, loved as good as it gets. Mm-hmm. But that's the only OCD now is we bring clean, forks to the restaurant like he did in the movie. People say, oh, I'm so OCD. Yeah. Let's talk really, though, about someone suffering from OCD, what they're really going through.
Yeah, we do hear that a lot. Or the flip side, if I could just have a little OCD.
Oh yeah.
I hear
that would be great. And so I liken it to this. Imagine, and everyone's going to hate this example. I'm just going to give a trigger warning right now. But imagine if I walked into a room full of people who were struggling with weight and I said, have you thought about a little anorexia?
Oh.
How do you feel when you hear that?
Just immediately shudder.
Right. That's how people with OCD feel when they hear, wouldn't it be great if I just had a little OCD? Mm-hmm. Okay. Yep. So I say that just to set the stage because I don't understand why we'd ever recommend anyone to have a small bit of a mental health issue as a way to help them.
Right.
Right. It just doesn't work that way. And OCD has been a joke and a trope for a lot of things, or this idea that it's a personality quirk. Oh, we all have a little OCD, right? Well, that would mean that if I drink once a week, I have a little substance use disorder.
Right.
Mm-hmm. So I just
have an individual that has thrived.
Right.
Which is a good thing. They've thrived. So, it must not be that big of a deal because so-and-so's fine.
Yeah.
Well, I wonder if you can tell us a little bit because I don't know a ton about OCD and I'm like, my big question is like, what is it? Like, what's happening in the brain that gives you that OCD diagnosis?
Sure. So there's two things. There's obsessions, which are thoughts or images or urges that we may find to be intrusive, inappropriate, unwanted. And we feel that we must neutralize them. And if we don't, maybe something terrible or awful or bad will happen. And it could be my fault or it could happen to me. And it would just feel better if I were to somehow get rid of that. So that leads to a compulsion. And a compulsion is a mental or physical behavior that we do to attempt to neutralize that obsession. So you were talking about, what the things you see on movies a lot, right? I touch something, I think I have a germ, I go wash my hands, I feel better. That's the tip of the surface. Because OCD attacks the things that are the most important to you and the things you love. So it could be, I was walking past this family in the mall and they had a little child and I noticed my arm moved slightly toward them. Did that mean that I wanted to steal their child, take them in the bathroom and molest them and then return it to the family before they knew it was going to happen? That's OCD too. I was driving over a bridge and I had this thought, what if I just turned the wheel really hard? And I didn't, and I made sure that I didn't, but now I'm never going to drive over bridges because what if I were to do that and I were to kill everybody in the car? I'm actually a very dangerous person and I should never drive over any kind of bridges ever again, right? That could be something along those lines.
So how do you diagnose that?
Well, we really take a look at the interference that this has on people's lives, right?
Similar to what we've done with substance use.
Just like you look at substance use. Yep. What is the interference on someone's lives? An hour or more a day of obsessions and compulsions fits the bill really well for meeting criteria for obsessive compulsive disorder. Or an interference in your life. You're not able to function at work or school or family life or something like that. And these things grow over time, right? You see more and more occurrences of compulsions as a way to try to manage the whole experience. And people will tell you the reason that the bad thing hasn't happened is because I did the compulsions. I liken it to this. Right. If you ever come to the NOCD offices in downtown Chicago, you might see there's a homeless person that walks around with a 30-foot bamboo pole. And if you ever go up to them and say, why do you have a bamboo pole that's 30 feet long? They'll say, well, it keeps the giraffes away. And if you say, well, but there's no giraffes in Chicago, they'll say, yes, the pole works very well. Exactly. And that's kind of what it's like with OCD too. The reason these things haven't occurred is because of the compulsions. And if I were to stop them, there's a chance that this thing, awful, horrible, bad thing could happen. And then it would be on me. It would be my fault. And I don't know that I'd be able to handle that, or I could deal with that responsibility. So isn't it best just to do it just in case?
Do you see that with, I'm thinking about the family members, right, of people who may be struggling with OCD. Do you see a lot that they try to use logic to get people out of this? And I imagine that does not work because it's not a logical situation.
Exactly.
How do you see that kind of play out in family dynamics?
Very simply, think of it this way. OCD logic is different than non-OCD logic. So if you don't have OCD, you're going to bring your logic to the situation. But the OCD logic has one more, but what if, than you have an answer to.
Yeah. And you can never satisfy the what if.
Right. No, it's an unitchable or unscratchable itch, right? It's insatiable. Yeah. It always wants more. No one with OCD in the history of OCD, as far as we know it, has ever said, hey, you've finally done enough compulsions. Congratulations, I'm out of here.
Right.
Right? It just never happened, right?
Let us know when we find them.
Yeah.
Right.
Yeah. And sadly, for a lot of people, you see that in substance. Can you ever do too many substances? Well, dying, is the for unfortunately for a lot of people
the outcome anyone's looking for.
Exactly, but that seems to become like the end where sadly so many people go to. And so, what can we do to stop people from doing compulsions? What can we do to stop people from using substances? Because we know that that's the best thing for them to be able to live the life they want to live. And not the life driven by a substance or not the life driven by OCD.
Reminds me of our harm reduction model.
Yeah.
Really, as we talk about that, if somebody has used X number and you've moved them down, they don't drink as much today as they did yesterday, and continue, you're reducing harm. You might not be at abstinence, but you're reducing harm, trying to get them healthier, get them on a better path.
Yeah, and we do that through the therapy that we do is called exposure and response prevention therapy, where we purposely expose people to whatever those thoughts and images and urges are, and we ask them to not do the compulsion or to decrease the compulsion.
Which has to be terrifying in the beginning.
Absolutely, right? I mean, if you really believe that if you don't say a prayer within 5 minutes of thinking something negative about someone, they'll die, you would want to say a prayer, right? I'll show you real quick. I'll pull it out my wallet here. I was doing that very thing with someone 18 years ago who finally was willing to work on it. And we got to a point of them thinking something negative about their parents and then not saying the prayer, because that's what we needed, because they were doing hours of praying. And so I said, well, you know what? I'm going to do it with you. I'm going to think something negative about my parents also. And then I also won't say the prayer. And in fact, I'll even take it one step further. I'll hope something happens to them. So if you could confirm that line 3 on that card right there says, I hope my parents die tonight, please God. And there's also a 666 on the bottom of that card as well. Yes. Okay. Now,
oh my gosh,
that's been in my wallet for almost 20 years. You can see how worn it is and everything.
You did that to show them.
My parents are still alive. They know the card's there also. And they're like, screw you, we're still here. But I did it because I wanted to prove a point. I wanted to show that person that no matter what, in the future, if you ever see me on the streets, if you ever see me at a conference, I'm never going to take that out of my wallet until my parents are actually dead. Because I don't believe for a second that has any influence on their lives whatsoever. But OCD says, yeah, but what if it does?
What if it does? Just in case.
So would it be best?
We talk about, it's interesting. We're at this conference and it's sports themed. superstitions run through sports.
Oh.
I'm not going to take my socks off because I got a hit yesterday.
Listen, my high school volleyball team won states because I wore pearls.
Sure.
And went to Chipotle every day. I heard the story, right?
Season.
Yeah.
But we do. We have superstitions, right? We do things. We might not entirely believe that the Chipotle won.
Right.
But it didn't,
Maybe.
it didn't
But
hurt.
what if it did, right?
What
That's flip side. What you're saying is, but what if it did?
Yeah.
What if we really had to go? Like you had that thought, what if I really didn't? And it's interesting, that intersection of sports. So what I'm curious about, our listeners are often substance use clinicians.
Sure.
And correct me if I'm wrong, I think the incidence of OCD isn't a high number per se compared to many of our other mental health diagnoses. It's a smaller number that we might not come across as much.
Yeah.
And so for our
1 in 40.
clinicians, 1 in 40. Okay. So for our clinicians, how do they one is a multi-part question. One, how do they recognize it? And then if this isn't their area of expertise, which it often isn't, what can they do so that we can help that individual?
Great question. I'll go in reverse. Collaboration is key.
Okay.
Right?
Yep.
I know that many of the therapists at NOCD are not substance abuse experts, but I don't want to kick somebody out just because there's been substance use, right? So I want a collaborative effort. I want you, we call our patients members. I want the member to have us doing work on ERP, and I want the member to have a substance abuse counselor who's working on them decreasing that substance use. And we'll see that as that substance use goes down, our ERP work goes up. And hopefully they get to a point where they've done enough ERP. If OCD's been the driver of the reason for the use of substances, they don't even need the substance anymore because they learn, oh, wait, I can live with the thoughts and the images and urges that are in my head. I don't need to use substances as a way to do it.
Yep.
For recognition, it is very important for people in the substance abuse world to try to find out if someone does have these thoughts and images and urges, that they are making all attempts to try to do whatever they can to not have them anymore. And it's kind of the pink elephant effect, right? The moment we bring that up and tell you not to think of it, it's really hard to do. Sometimes when I'm in larger groups, I really piss off the audience because I'll start saying, lice, they get in your hair and they crawl around in there, and then they have little babies, and then they dig into your follicle, and eventually the audience, you just see the hands start to go, even on the Zoom, you just see people starting to scratch and everything. We are so suggestible, right? That's all that it takes is about a minute of talking about lice and people want to start scratching their hair. Well, OCD takes advantage of this. And is like, don't forget, what if? Oh, what if that? The two worst words you can ever utter are what if, as far as I'm concerned, because OCD just grabs onto those.
You can ask that.
Absolutely.
Ad nauseum.
100%. So if anyone working in substances could really ask people, do you have any what ifs that are really out there that drive, or are there any thoughts or images or urges that you experience that are the predecessors to using? Right? Because you don't like those, you don't want those, and you want them to go away right away. That would be amazing to find out. Do people experience panic attacks? And they've learned that as long as I stay on a certain substance, I don't have a panic attack. We've got great treatments for panic, right? We do interoceptive exposures. We do things like we run in place and hyperventilate and breathe through straws and spin in chairs. We teach people how to handle the symptoms of panic so that they don't have to be worried or overwhelmed by panic. We can help people with phobias. We can have people with social anxiety work up to going up to someone and making a mistake on purpose and learning that they can handle that very thing, right? So that kind of stuff is out there. We have excellent behavioral-based treatments for this. A lot of people have an idea that it's all talk therapy. Like, I've never once in my career of 25 years talked somebody out of being anxious. It's just never happened. I've behaved people out of being anxious, right? And that's what I try to do all day long is, how can I get you to change your behavior? And how can I teach you that you can handle things that you right now don't think that you can? I think that people are much stronger and the brain is not fragile at all. I think people are much stronger than they give themselves credit for. And if we allow people to learn that they can handle things that are uncomfortable, they don't need other safety behaviors, right? And you talked about substance use safety behavior. There's 5 safety behaviors that I talk about all day with people. Number 1, avoiding all of the things you're afraid of. Number 2, seeking constant reassurance that you'll be fine and everything will be okay. Number 3, distracting yourself whenever you do have to face a fear and not fully engaging it and allowing yourself to learn to handle it. But I only handled it because I was distracting myself. Number 4, substance use. And number 5 in the OCD realm, compulsions. If you do any of those 5 things as a way to deal with a stressor, you're not allowing yourself the full potential of learning that you can handle things. You're teaching yourself, I can only handle things through these other things. I need these filters as a way to be able to handle the world. And I just want people to learn, no, you can handle the world without those things. They aren't necessary.
What an important lens. Really.
That like transcends
everything.
Just that. Yeah. I'm like, this conversation just became about life. You know, like, that's right. So... Because what I was thinking in some of what you're talking, I'm thinking about the person out there who's like me, and I'm like, do I have obsessive thoughts? Do I have right? And it's like, okay, but if I don't do the compulsions, then that means I don't, you know what I mean? Like there's all this like internal.
Surely each of us at some point.
Of course. Yeah.
Well, we all have weird thoughts. I mean,
right.
Who hasn't driven over a bridge and thought, I could totally turn the wheel.
Right. I'm like,
right. I mean,
yes.
So, but that's a great example.
Avoid
don't avoid it.
So that's it's kind of the twofold piece.
That's the second part,
which I want to make sure people hear.
Yeah, it's an important piece. Okay, because I want you to tell us about NOCD.com too. I want to make sure that our listeners know about that as well.
Yeah. So the official title is NOCD. I mean, we are at NOCD.com if you want to find us, but that is. So NOCD is an online platform for the treatment of obsessive compulsive and related conditions. So we work with OCD, hoarding. We work with body-focused repetitive behaviors, which are trichotillomania or hair pulling, and excoriation, which is skin picking. Okay. And we also work with tics. So people who do, like you hear Tourette's or something of that nature. We do various therapies for all those things. So we have an exposure and response prevention basis for OCD and other anxiety disorders. We will treat other anxiety disorders. All online. Oh. Yep. We do habit reversal training, which is the treatment of choice for the body-focused repetitive behavior work. You teach people how to not give in to the pulling and the picking and things. And then hoarding work, we can do like a 4-box method, cognitive behavioral therapy work for that also. And it's nice because in the old days, pre all of this, I'd have to drive for an hour to get to someone's house. I'd be at their house for an hour. I'd have to drive back home. It was a 3-hour charge for someone. And now I could just say, turn the camera on. Let me just see your house. So it's much more efficient. And it could be still amazingly effective. In fact, we've published the 2 largest studies now in obsessive compulsive disorder and showed that it is just as effective doing it online as it is in person. Good. Yeah, there's no decrease.
And the response, what's been the response to NOCD?
Amazing. When I joined in 2020, we had 18 therapists and we were in 3 states, and now we're in 4 countries. And we have a network of over 700 therapists. Awesome. So it's been amazing. And, back then, almost all OCD specialists were in large cities and took cash. That was it. And now with just a phone, you have access to someone who's trained in your area. You don't have to leave your home, and we take insurance.
And our clinicians, if they aren't familiar with OCD, they can reach out to you all in terms of collaboration and talk through that. Because I think that's the other piece. If they do recognize somebody and they're not sure some of the behaviors,
and we'll do the diagnostic and everything. So they don't even have to worry. If there's a suspicion, from what I've described so far today, they think that sounds maybe, we'd be more than happy to do the diagnostic on someone and help to confirm the diagnosis and let people know what we're doing. And then we'd love to get a release between that clinician and us because, again, we want to collaborate, right? Yep. I don't want another Riley. I don't want to see another person die. And even back to you were talking about the residential. One of the reasons we did the residential was because Riley went to residentials for OCD and he got kicked out because he was med seeking at the residentials.
Oh, interesting.
He just, or they put him on a benzodiazepine as a way to try to help him. And that set him right back down.
It's an important piece, I think.
Oh.
You might want to talk about medication just a little bit. I know it's not a clinical session, but okay. I think that's helpful to know because the automatic thought, right, is a lot of times those benzos, and that might be terrible for someone with OCD.
Let me just make it clear. Benzodiazepines are not required for our therapy. In fact, I won't do therapy with someone who is actively taking benzodiazepines without working on some kind of reduction. And the reason is benzodiazepines create state-dependent learning. If you do exposure and response prevention therapy only while on a benzodiazepine, you will only learn how to handle OCD while on the benzodiazepine. It will not translate to the non-benzo use state. And that's, again, what we call state-dependent learning. I did my senior thesis on this in college. I've been involved in this work for a very long time. And the PRN usage of a lot of these meds is a problem. We see that now today, too, with vaping and various other things that are just so easy for kids, even especially to get, hey, I just took a hit. I'm ready to go. No, because again, we're going to create that state-dependent learning experience in that situation. And I want to set people up for success and not for failure.
Is it true? I'd heard this, and so I want to verify it, that antipsychotics could make the obsessions worse.
So we will use atypical antipsychotics at a very low dose for people who have low to no insight OCD. Most people with OCD have good to fair insight. Most. Not all. Most. For those who are at the very low end, a low dose can help crack that door open a little bit because they truly believe in their obsessions as being true. Right?
I see.
And that's why it's also called a delusional OCD.
Okay.
So that has been helpful at times for some folks.
Gotcha. Okay. That makes more sense. Did you remember that question?
I have a different one, Nat. This happens to me all the time. But I'm curious about something we hear a lot about right now is there's not enough treatment for youth. And I know that I had a family member who was under 18 struggling with OCD, and there was not any, the options were so slim.
Yeah.
So I'm curious, one, if y'all do that, but two, does it make a difference treating it earlier, finding it earlier? Like how does that play into the efficacy of treatment?
Earlier the better. We will treat kids as young as 5.
Oh,
wow.
We involve the families. That's a key component. And we teach the families also about family accommodation. Because just like in substance use, families inevitably give in and think they're being helpful when they're actually becoming involved in the problem, right? And how many times has someone with substance use or OCD said, I promise this is the last time?
Oh, yeah.
Yeah.
Right?
Honestly, meaning it, too.
Right,
like, really wanting it meaningfully.
Yeah. There's so many parallels between the two, which is, again, why I loved working at Foglia. And I could do a group with people who had one, the other, or both, and they'd all go, oh, yeah, that makes a lot of sense.
Right. They can learn from each other.
They really did. Yeah. They really did.
Which is really nice.
There's a feedback mechanism in the brain, right? Nobody wants to be uncomfortable. So if I have OCD, I'm going to do a compulsion. If I'm going to do withdrawal, I'm going to do a substance. They serve the same purpose. How can I decrease discomfort? We have to teach people how to handle being uncomfortable.
Yep.
And in our world, we've kind of had this notion that shouldn't happen. No one should be uncomfortable. Everybody should get a trophy. Everybody's a winner, all these things. And I don't like that, right? Because I don't think that it sets people up for success. If you learn that you can handle failure, if you learn that you can be uncomfortable and you can live through it, you can handle it, you're not afraid of it anymore. But if you've got this notion that discomfort is a big no-no and I should never feel that whatsoever, you're going to do anything that you possibly can to feel as good as possible right now.
So I know we're a little on. We're running out of time.
I'm sorry.
But no,
I could talk
because I can talk
another
forever.
7 hours on this.
I could go on forever. I did want to, this might be a little bit of cracking open an egg with 5 minutes left, but we didn't talk about the intersection of trauma. And I think we'd be remiss if we didn't, because I just heard one of your podcasts about the intersection of trauma and OCD, we talk about adverse childhood experiences. We talk a lot about trauma. Now there's the conversation of trauma as the, quote, gateway drug for substance use. So if we could take a few minutes, because I think we'd be remiss if we didn't talk about that intersection.
Well, my first controversial comment will be trauma is not a necessity to have OCD or substance. And there's a lot of movement in therapy right now that wants to find the trauma for absolutely everything. So let me just make it clear. You don't have to have a trauma to develop OCD. You don't have to have a trauma to develop substance use. Some people are not going to like me saying that, but it's the truth. That being said, OCD is a very opportunistic jerk of a disorder that will say, oh, you've been through something very difficult, awful, horrible. I can help that never happen again if you just do these compulsions.
So it's kind of the brain's way of protecting itself, essentially.
It can be, right?
This is how we make sure we don't get hurt again.
There we go, right? OCD is a manipulator. So you don't do a compulsion? Oh, okay, well, how about a panic attack then, right? That kind of thing.
What a visual. It's a manipulator. Wow.
It is. It's a total manipulator. You've had this thing happen. You wouldn't want that again, would you? Why not do this, right? So whether it comes from the front or the back, OCD is going to do anything that it possibly can to get you to do some kind of compulsion. And it can make itself related to anything that's out there. Absolutely.
Well, I think that's interesting too, because that's the way we talk about substance use disorder, not necessarily as a manipulator, but as this thing.
Opportunistic.
Well, this just like almost like a living entity in your brain that is doing things. And I don't hear that in a lot of other mental health disorders outside of substance use. And now you using that to
we use it all the time with OCD.
But it's so true. Like addiction can warp things for you and it'll snake its way in where it can find a spot. And it sounds like OCD will
totally
do the same darn thing.
100%. OCD has one mission, which is for you to do a compulsion. That's it. That's the whole goal.
Boring mission for it.
Yeah.
Like, but I mean, man, is it effective?
It eats compulsions for breakfast, lunch, and dinner, and it is always hungry. Wow. So you don't do compulsions, it's going to scream. And it's going to beg and plead and bargain and everything. And that is the withdrawal that people have to go through in OCD is all of that horrible feeling internally. You know, in substance, we have it internally and externally, right?
Yeah.
The throwing up, I feel like I'm dying, all these things, but you have to get somebody through that experience to learn that you can live on the other side, right? You can't overcome a substance use disorder by using more substances. And you can't overcome OCD by doing more compulsions.
The intersection. You're right. We could talk about this for a while, but I'm so glad. First of all, thank you for coming.
Of course.
Thank you for having the conversation, for intersecting with our field, for doing the work that you do at OCD. I think really getting the word out there that this is something that is treatable, that you can, like you said, you can live with it. We can figure this out. And that it's just getting out of the shadows, really, and taking it out of a caricature that it's become. Yeah. And you all are doing that, and we're grateful for that.
Well, thanks for having me, and look forward to my talk on Wednesday for everybody to come to.
Yes. Well, we're excited. Thank you. And they can find you at NOCD.com.
NOCD.com or NOCD as just if you're looking the spelling. But yes, it's NOCD.com.
Well, thank you for joining us.
Awesome.
So much.
So I could have had that conversation for about 2 more hours. Let's start there.
Yeah. Oh, I'm like, I'm ready to go find Dr. McGrath and ask a few more questions.
Yeah, more about it. It's just the intersection between substance use and OCD, just learning more about OCD. That whole conversation around safety, that safety behavior.
As someone who maybe doesn't specialize in substance use, his ability to understand it for what it is, which is a disorder versus another thing to use to stigmatize a client is really powerful.
It really is. I'm really excited for you all to get your feedback. And if you've got more questions, maybe we can try to bring them back. Anytime our listeners want somebody back. We're going to try to get him, and this conversation could keep going. So we're just grateful he made it, and grateful to NOCD for bringing him to the conference and to the podcast.
Awesome.